Welcome, everyone. Today, our guest is Dr.
Hold on, just one second, Greg. I have a couple connecting to audio
Oh,
still.
there we go.
Sorry.
Welcome, everyone. We good, Lori?
I think so.
Okay. Our guest today is Dr. Ron Peterson from our own Whitehall coaching staff. Dr. Peterson is a periodontist. He practiced for I don't know how many years. He can answer that. He was the president of the Arizona Board of Examiners. He's had some other honors to his name. He's quite an academic and an amazing coach. Several of his clients have been able to kind of live out the AWOL dream where they don't practice. They literally run an associate office or sit back and watch an associate office run. So he's going to talk about the challenge that we see with hygienists coming into our practice with their own culture. Some of them, for example, believe they're like a hammer and everything's a nail. They are like hygienists that see everything as perio. And he has some statistics he's going to quote about the impact that can have on your practice and what you can do about it. So, Doctor, could you complete my presentation on your curriculum vitae and then go into your presentation?
Sure, happy to. Thank you, Greg. Yeah, I practiced in Arizona for over 20 years. Before that, I was in academics and taught at 3 different universities. I'm board certified in the specialty and was president of the State Dental Association, 8 years on the Board of Dental Examiners, 2 years as president. President of the Western Regional Examining Board, was very involved with licensure and a whole bunch of committees. I just kind of enjoy that kind of stuff. And as a result, as my wife says, I have a head full of useless information. And very true, with the exception of what I do now. In coaching, a lot of questions about licensing and about legalities and about boards and about lawsuits, all those things come up. And that's kind of my worthless information, but it has value here. Coaching is a lot of fun for me, and working with the hygienists is especially rewarding, and it can be challenging. So are any of you hygienists? Are you leaders in the office?
You can start there. You want?
There's one. We have one hiding back there. Okay. Okay, good. Well, let me talk about some of the things Greg just said, because hygienists are highly trained, highly valued parts of our team. And frankly, they're pretty much indispensable when you get right down to the things that we ask them to do. And if we have a challenge with hygienists, sometimes it is they don't really participate as part of a team. They tend to not. Now, again, I'm not trying to paint everybody with a big brush, but when we run into problems, that's often what it amounts to. But here's just talking about what we like to see happen in a general office, as opposed to a perio office. Is I guess the first question is, how many people start their examination process through the hygiene department? In other words, hygiene sees them before the doctor or in the same visit as the doctor. Do most of you do that, or you got a yes? Any others do not? Doctor sees patient first?
Yeah,
We do.
but then in the same visit, the patient will then slide over and see the hygienist. So the patient's there for one visit, but doctor first, hygienist second. Most of the
Total time, 90 minutes, roughly?
Yeah.
Roughly 30 with you and 60 with the hygienist, or something like that?
Yep.
Okay.
Exactly.
Yeah, a lot of ways. There are a lot of ways to do the exam process, and but I don't have a problem with the hygienist doing a lot of information gathering, and that is not illegal. the question often comes up, if the hygienist is gathering all this information, doing the probing and then creating the perio treatment plan, is she stepping beyond her legal limits? And the answer is maybe, but probably not, as long as things are done in consultation with the doctor. So what do we, a couple basic things to remember when any new patient comes in. You have, as an office, legal obligations. These are not suggestions, recommendations. These are legal obligations. There's 5 things that are involved. First one is you have to do a thorough examination. Secondly, you have to record the findings. Thirdly, you have to discuss the findings with the patient. Fourth, you have to make treatment recommendations. And fifth, you have to discuss the potential outcomes of the treatment options that you present. And as I said, those aren't suggestions, those are legalities. If you go to court and an attorney starts asking you about your examination, every one of these things is going to come up. And they need to be recorded, they need to be properly documented. Anything you do needs to be documented. Essentially, in the eyes of the law, if it's not in your record, it never happened. So document, document, document. Now, for the hygienist, these are just as important as for the doctor. So in some offices, the hygienist will see the patient first and record findings, meaning caries that she might see, cracks, breaks in the teeth, look at all the dentistry, look at the margins, see if there's things that are breaking down. Then fourthly, do a soft tissue exam. And she can record all those things, and there's no problem with that. Hygienists learn how to do all that, correct? You learn all that in hygiene school. So you're not violating anything, but the doctor has to confirm and make the treatment plan from that information. So just like when you go to see your physician, you'll see 2, sometimes 3 people taking information, taking recordings, drawing blood, whatever, before you even see the doctor. And that's just kind of the way healthcare is going now. So use your staff to their skill levels. And recording that information is absolutely fine. In fact, it becomes an integral part of our maintenance program, because one of the problems we see with hygienists as kind of a general rule is when they see patients for recall, if there are incomplete procedures on the treatment plan, we pretty much depend on the hygienist to remind the patient of those things. For example, Mrs. Peterson, doctor recommended a crown on that lower left tooth over a year ago. I'm looking at it today. I don't like the way it looks. You really need to get that taken care of. That's the sales pitch. It's not much of a sales pitch. You're just telling them the facts. That was recommended. You need to get it done. It's getting worse. And if the patient says, yes, I know, the hygienist then can easily say, would you like me to check and see if we can work you in while you're here and get it started for you and save you a trip back? Half of the people statistically will say yes. And that's called same-day service. And same-day service is how you grow the production in your practice. So, and the same goes with anything that was not previously noted. We want the hygienist to do an evaluation, a very thorough evaluation when the patients come in for recall. The doctor's going to come check it, but the more time the hygienist spends recording it accurately, the less time the doctor will have to spend doing his part of the exam. Doctor, do you ever work with more than 2 hygienists at once on the same day? You ever have 3? Where you have to check all the recalls or more?
Yes. Yes.
All right. When do you have time to do dentistry? If you've got 3 hygienists going, it's pretty tough, isn't it?
Mhm.
Because I know most states have a law now where you have to see the patients once every year, roughly. So you can go every other time if the hygienist says, hey, everything looks okay. But still, most people go in. But even if it's short and you're there for 7 minutes, 5 minutes, 10 minutes, you do that 3 times in an hour, that's half of your day, just doing the hygiene checks. So what we found is it can really cut into your production because of all of the things that you're looking for at your recall examinations. So this is an instance where relying on a well-trained, dependable, insightful hygienist is to everybody's advantage. They're trained in it. They know how to do it. Let them do it. Let them come in. When you come in and look down, she should have a list there of the things that she saw that are concerns. And you can then look at them and discuss them. Now, I'll give you a little hint. If there's a process we call buying back. And if you want to get kicked, this is how you do it. The hygienist says, I have Mrs. Peterson here. This tooth is breaking down. I can see that the crack here is getting worse. It's getting brown in there. And I told her it looks like she's probably going to need a crown on it. Okay, now she didn't say she's going to need a crown. I said, it looks like it might need a crown. Then you come in and go, nah, we can wait till next time. Because she's already convinced, told the patient what was going on. It was legitimate. Patient said yes, and now the doctor comes in and says, nah, let's watch it for another 6 months. Use your judgment, of course, but that will humiliate the hygienist. And if you're not going to agree, which is okay, do it delicately. Be extremely delicate and discuss it and say, boy, I see what you're seeing. That is a mess. It's really getting worse. It would be good if we could do it as soon as possible. I certainly think we cannot wait any longer than the next appointment. In fact, I'd prefer to do it sooner. That way, you're not arguing with her. You're not telling her she's wrong. You're doing it delicately. You're agreeing, but you're stressing urgency in addition. That's a hard thing to do. So the whole idea, though, with the hygienist is the more they can do for you, especially with your recall patients, the more it's going to help your production. It really is. And again, it's an interesting just study of your own time to look at how much time you spend doing hygiene checks when you have 2 or 3 hygienists in a day. Just how many minutes it takes you away from being productive. And it can be actually kind of scary. I have another doctor that I worked with up in Michigan for a number of years. And he said he had a hygienist who he hired, paid hygiene wages, and all she did all day long was administer local anesthesia. And I said, really? How much time does that save you? And we went through it and sat down, and it came out to almost 2 hours a day of time that he could now be productive because he had someone else administering the local anesthesia. Now, this only works if you have an adequate number of treatment rooms, obviously. You've got to have enough treatment rooms, but using the hygienist in that manner is incredibly powerful for giving you more treatment time. If you save an hour in a day, that's at least the equivalent of a crown. So add another $1,000 plus to your production in one day. That more than covers your cost of having that employee there for the day, giving the local anesthetic. And And frankly, I have other doctors that do that now too. And it isn't even so much about the extra time anymore. They said they just really like not giving the local anesthetic because of it's just stressful thing to do, and especially when you're running back and forth. So they let somebody else give the shots. I think that's an interesting effect too. Greg, did you want me to talk a little bit about some of the studies we did with treatment presentation?
Please, if you would.
Sure. We did a study in an office, gosh, it's been 10 years ago now, I think. Here's the setup. This was an office in Florida. Doctor that worked about part-time, had a part-time associate, but he did a lot of marketing, brought in roughly 120 new patients per month. And these were this is pretty much pre-website marketing. It was almost all postcard. 120 new patients for essentially the equivalent of 1.5 doctors is quite a few new patients. That should keep them busy. Well, what we found, what the doctor's complaint was, is my practice is shrinking. Now, what does it tell you immediately? They're bringing in 120 new patients a month, but their recall is shrinking. They've gone from 2 full-time hygienists. They were now down to 1 hygienist 4 days a week and 1 day a week. So they were losing patients, losing recall patients. So it tells you they're losing more than they're gaining. So we wanted to see where people were going down the drain. So we put together a retrospective study, which means essentially we're looking back at what's happened. So the way you create a study like that is you gather data from a previous date, and we went back about 14 months or so, and then had them pull out the records of 120 patients, and we wanted to know what happened to them. So here's how we broke it down. One group were people that had an examination and were presented a treatment plan and never came back for anything. So they were there for the exam, gone, never seen again. Second group had an examination and treatment plan. They did something, but then never came back again. In other words, they were no longer on the recall schedule. And then the third group were people that had some work done and were still on the recall schedule. So just from that first breakdown, groups 1 and 2, people that never came back either at all or did something and then never came back and were not on recall anymore. That was 90% of the new patients that they saw. 9 out of 10 didn't come back. So then we wanted to break it down further. We wanted to see what's going on. Why are these people leaving or not staying? And the common factor was periodontal diagnosis and or treatment. What we found was every patient that didn't come back at all had been presented 4 quadrants of root planing, scaling, so forth, essentially $1,200 treatment. The second group, who had something done and then never came back, went through the 4 quadrants of treatment and then never came back. So you got 2 groups, 9 out of 10 people that were offended for some reason and never came back. So, pardon me, we found that the person who was doing the examining and the treatment planning was the one hygienist that was still there 4 days a week. She also did all the perio treatment, and she was on commission. And that raised a bunch of flags. What we found was she was doing really well. In fact, she was making over $150,000 a year. And there were enough patients coming through that even though a large group of them said no thank you and left, enough of them said yes that it kept her busy, but the doctors didn't have anything to do because the patients were all leaving before they had any of the restorative treatment done. So you see, she was happy, she was making money, but the doctors' production kept dropping because the patients weren't staying, weren't getting their treatment done. The real story of what was going on here, because then I went deeper and had a bunch of charts pulled and looked at them, is these people were being grossly overdiagnosed, grossly over treatment planned, and frankly, she should have had a complaint filed with her against her at the board, because looking at, again, the limitations of x-rays and radiographs and pictures, they're never perfect, but I certainly know advanced bone loss from no bone loss. And I can tell you that most of these people didn't need anything like that. In fact, when I went further and looked at the time frame, their typical prophy appointment was an hour. Their typical 4 quadrants of root planing was an hour and 15 minutes. So there was a 15-minute difference between a regular cleaning and a $1,200 root planing and scaling. So I say this not as an indictment against hygienists at all. This is the worst I've ever seen, but it was very powerful from a different point of view, and that is the reluctance of people to understand and accept periodontal treatment if they really don't see it coming. Because it is typically, as Greg, you've said, it's part of that perfect storm. You know, you've got some unexpected treatment presented by someone they don't know under what they think are false pretenses. So these people are coming in for their $99 new patient special and told they needed $1,200 worth of periodontal treatment. And even assuming they all needed it, they weren't going to do it. So it told us a lot about the resistance of patients to periodontal problems or to periodontal treatment. So then the question came up, how do you get beyond that? Let's make the assumption that all these people need periodontal treatment, but how do you get them to accept it? Whether it's localized root planing, 4 quadrants of root planing, or even some limited surgery. How do you convince them that they actually need it? Because they're coming in for the new patient special and they're expecting exam x-ray cleaning for $99. So the point is, you have to give them time to accept it. And there are ways to approach periodontal disease and periodontal problems that give them that opportunity. As hygienists all know, you have to talk to patients about your findings. What are you doing? I'm probing. This is a probe. This is how it works. This is a pocket. This is blood. This is pus. You know how that all goes. You explain to patients what you're doing and what you're seeing. And what it really gets down to is convincing patients that they have a medical issue going on. This is an infection. This isn't a little filling, which of course is an infection too, but periodontal disease is not, well, it's a lot more complex than just scaling your teeth. So approaching the patient, you have to inform them what you find. You have to show them signs of the disease and the breakdown. And you have to discuss with them as your physician would discuss a medical model. Mr. Peterson, I've shown you this bleeding. This is calculus, tartar, scale some off. These are pockets. This is what's causing the bone breakdown that we're seeing. I'm going to clean things up the best I can in the time we have allotted today, which may only be 20 or 30 minutes with a Cavitron. But when the doctor comes in, I'm going to ask the doctor to give you a prescription for an antibiotic to help clean up this infection. I then would like to have you back in 4 weeks so that we can take a look, see how much improvement there's been, and see if any further treatment will be needed. Doesn't that sound like when you go to your physician? You go in, you have an infection, and you have a wound. What do? They evaluate it, they clean it up, they dress it, and they give you a medication, and then they have you come back to see how much improvement you get. So it's a medical model as opposed to what we tend to do as dentists. You have a cavity, I'll fix it, it's fixed, good, you're done. Periodontal disease is an infection, and that's one of the things you have to get people to understand. So you give them their prescription, you give them an information packet, and if they have any sense, they'll go home and they'll get on the internet and they'll look it up and they'll see what's going on. When you have them back, you're going to see a lot of improvement, even if you've just done gross scale and placed them on doxycycline is a medication I prefer, by the way. Doxycycline, 100 milligrams, 10 tablets, 1 a day until gone. It's very effective against most periodontal pathogens. So when they come back after 3 to 4 weeks, the tissues are going to be tighter, healthier. They're going to look better. Tissues will have actually shrunk some, which sometimes exposes more of the calculus because it was subgingival before. But they're going to be, even more importantly, more receptive. They understand now. So when you discuss further treatment, you're going to have a lot more receptive patient. So that is what we call two-step perio. And it's really giving people the opportunity to accept the fact that they have a problem. Your hygienist has to be deeply involved with this for the support to work, but it is highly successful. We've been promoting this for 10 years. Isn't that about right, Greg? A little over 10 years. And we see great success. In fact, one time we were speaking to a group of hygienists, and probably 80 of them. And one group from Dallas, one of the hygienists raised her hand. She said, "We found another way to use that." And I said, "Oh, what's that?" She said, "Well, you know, sometimes when you're monitoring or trying to manage patients, mostly they're stable, but they're never quite where you'd like to see them. In other words, the pockets might be a 3 one day, and the next time they might even be a 5, and you clean it up real well, and they kind of come and go. But sometimes you'll follow people for years, and they'll be pretty much, you know, up and down a little, but suddenly they'll drop quite a bit. Things will just suddenly be a lot worse. Now, what are you going to tell that patient?" And I said, "Okay, tell me your experience." She said, "Well, if we say, 'Gosh, Mr. Peterson, your pockets have gotten a lot deeper.' Okay, so what do we do about that?" "Well, I've got to go in and do a really deep cleaning." "Well, what have you been doing every 6 months for the past 5 years? You know, half of a cleaning or a sort of deep cleaning?" It's a very awkward conversation, because what do you say? "Yeah, I'm going to do more of the same, only I'm going to charge you more for it, and I'm going to numb you up a little." It doesn't go over well. But if you tell your patients, you know, we've been fighting this infection for years. It gets better, it gets a little worse. It's mostly fairly stable. It's a chronic thing, but this time there's been a big change. What do we do about it? I'm going to clean things out, and we're going to put you on an antibiotic and knock down the infection, and then we'll take a look at you in 4 weeks and see how much improvement there's been. Now, doesn't that make more sense than saying, "I'm going to go in and do deeper cleaning because I haven't been doing deeper cleaning before"? So that's two-step perio. Those are just some of the ways that hygienists are a crucial part of your team. And we are happy to work with you on any of these things we've discussed. If you have questions, let us know, and we can set up a time.
Dr. Peterson, a couple questions.
Sure.
You know, if we don't handle this right, we run the risk of hygienists telling someone, maybe even the board, that we're downplaying what patients need. can you reassure us that we're 100% doing our job?
Yeah, so what they're talking about is negligence. Negligence, well, let me back up a little. Goes back to what I said at first. Everything that you say and discuss with the patient and those five requirements that I said, those need to be fully recorded. And you need to be sure that you are absolutely in line with the requirements that are there. So negligence or benign neglect, not even benign neglect or neglect of any kind, is when you fail to do one of those things. So if you don't record the pocket depths, then you are being negligent. If you see pockets and they're getting deeper and they're bleeding and you don't discuss that with the patient, then you're negligent. If you don't make adequate recommendations, if you say, no, we're fine, we'll just watch it, and they're 7, 8, 9 millimeter pockets, that could certainly be considered negligence. So negligence is failure to inform, essentially, and failure to enlighten the patient about their true findings. So, or, you know, we used to see things all the time where people wouldn't even write down what the pocket depths were that they were dealing with. Or one guy one time wrote them all down when he did the exam, and then after they cleaned the patient up, everything looked better, so he erased them all. So I said, no, that's not going to work. You have to keep a sequential log of what you've done and how you follow it. And, you know, that was 35 years ago or more. We're much better with how we treat and follow a lot of different periodontal and dental issues today. But doing periodontal treatment, as we discussed, is certainly not negligence by any stretch. There can be lots of difference of opinion on how you treat things, but let's say you do what I just discussed. You put them on antibiotics. The pockets at the reevaluation are all in the range of 4, 4.5, 3, and that looks pretty good. They're not bleeding. Would you recommend that they go have surgery done at that point? You know, I wouldn't necessarily. Your obligation is to tell the patient what their situation is at this point, what you will be looking for in the future. And if you see changes in the future that are indicative of deteriorating condition, then you are obliged to inform them and then perform whatever treatment or recommendations are necessary.
I don't know about you, Dr. Peterson, but I've actually run into hygienists who actually fear that giving this antibiotic, the patient won't come back needing 4 quadrants. Maybe only needing 1, and they're actually concerned.
Okay, so who are they really thinking about then, themselves or the patient? Because you're part of your obligation as a professional is to do what's right for the patient. In fact, that's the main thing. First, do no harm, then try to help them. So, yeah, I would call that someone who needs to maybe think things through if they're in the right profession.
All of the Whitehall coaches have observed hygienists literally destroying practices. It's easier to destroy an associate practice than it is an owner practice because of the connection is much stronger. But it wasn't until Dr. Peterson came along and started weighing and measuring and tracking the statistics that he was able to prove that a hygienist can put a practice on course for self-destruct. And so anybody have a question you want to ask Dr. Peterson now? Some of you might be wondering, how do I approach my hygienist with this? Anybody concerned about that? No? Because some of them, when you talk to them about 2-step, whatever, I'll go to the board. Because really they're just reacting to, either being princesses or whatever. So we've seen a lot of things, and when it comes to hygiene, and you want to have an associate practice, you're not going to be able to do it without the hygienists on board. They have to help us to feed those patients into the dental system as opposed to bouncing them out after a little hygiene treatment. So good. Dr. Peterson, anything else you want to add?
No, I think that, I mean, we could go on forever, but it's important that the hygienists and the doctors are on the same page with what they see. Calibration exercises, I think, are very important. It really helps to be sure that people are seeing the same things, recommending the same things, and being consistent with the patients. So just another little thing to consider. Thank you all. If you have questions, let Lori know.
One more. One of the things that we've had to resort to is when typically it's hygiene on commission that can get off track. But one of the things we've had to resort to is that only the doctor can diagnose periodontal disease. The others, oh, they can probe, they can do all these things. But as far as presenting it to the patient as needing $1,200 or $1,500 worth of treatment, that's the doctor that does that. Doctor, you okay with that? You good with that?
Oh, yeah, that's fine. I mean, look, doctors have to realize everything that happens in their office is their responsibility and their liability.
Right. A lot of times they first turn to the hygienist and say, wow, I'm paying you a lot of money. Why don't you make me some money? And they see Perio as maybe a solution, only to find out later it got carried away. Anyone have a question for Dr. Peterson? Just wave at us and we'll make sure you get your question answered. All right, and you can contact us and we'll put you with Dr. Peterson if you need help. Some people have had hygienists that are so hostile, they won't talk to anybody that's not at their level or above in their mind. So hopefully you can achieve that, Dr. Peterson. All right, Lori, what's next?
I guess that's it for today. In 2 weeks, we'll continue with leadership training.
Thank you, everyone. And thank you, Dr. Peterson.
Thank you.
All right.
Thank you.